All right, it looks like people are making their way in. So we will go ahead and get started now. Welcome back to day 2 of Society for Digital Mental Health. As I said, we're thrilled to have you here and excited about the lineup for today's programming. What I'd like to do, I have the distinct pleasure. My name is Bethany Teachman, first of all. I am on the Society for Digital Mental Health board and also the program chair. So I've had the pleasure of being involved in some of the planning for these events. So hopefully you're able to see my slides there, because I have the distinct pleasure of announcing our poster award winners. So many of you were at yesterday's session. We had about 80 posters that were presented and just fabulous quality work of really, really interesting cutting edge research that's happening. And from that, we've selected 5 student poster award winners. Please join me in congratulating Bailey Taple, Donovan Ellis, Ellen Knowles, Eileen Wong, and Yasling Reyes for their outstanding work with their posters. And thank you to them for the presentations yesterday. In addition, I would like to take this moment to add to the many thank yous that we need to do to recognize the incredible work that people put into this. Yesterday, David thanked our board and the amazing program committee that I worked with, just a fabulous group that put in a ton of effort to bring the conference to you. And today we'd like to also recognize those who are doing technical support, our dissemination team, and our many moderators. So the technical support was led by Adam Powell and Emma Wolf, with help from Olga Barnes, Tanvi Laktakia, and Shannon Smith. And we've had a great dissemination communication team that's been sharing information not only with you, but also to those who aren't here or couldn't attend. And that's led by Shirley Wang, Cesar Escobar Vieira, and Sarah Hill, with input from Miranda Belzer, Nick Jacobson, Yasleen Reyes, and Stephen Schuler. And then a wonderful group of moderators who have been incredibly diligent in helping to keep us on time, get everybody in and out of rooms, and help things to run smoothly. So a big thank you to all for their work. In addition, I'm excited to let you know about some growth opportunities that the Society for Digital Mental Health is pursuing. This year, for the first time, we are starting to launch special interest groups. And what I'm going to do is put some information into chat so you can read about the mission of the different working groups. But we're starting with a health equity SIG, a student SIG, and an industry SIG. And these really represent some of the core values of what the society is trying to accomplish. I'll let you read the descriptions, and wanted to let you know that what you'll see at the end of the day today is an email coming to you that will include 2 parts. The first part is an anonymous feedback survey. We'd love to get hear back from you about what you liked, what you want us to improve for the next round with the conference. So we hope you'll share information there. And then you'll get a separate link in order to let us know if you're interested in getting more involved with society and would be interested in joining one of the special interest groups that we're starting, or even considering a new one that you'd be interested in potentially taking a leadership role on. In addition, we're starting our first work group, the implementation work group. And again, the description of this is in chat, and a survey will be coming to you to let us know if you're interested. And I've shared the contact information for those who are playing leadership roles in that. A big thank you to Catherine McCapagal and Ashley Knapp, who are taking the lead on the Health Equity SIG, focused on thinking about how we can increase access to digital mental health quality services for those who've been traditionally marginalized and underserved. The industry SIG, led by Trina Histon and Kate Stamatis, which is really focused on thinking about how can we connect stakeholders and make it so that we're having good communication, good training opportunities, so that the research and academic and other stakeholder groups are really connecting in and well with industry, and that industry is able to do the important work of getting digital mental health services to people. And the student SIG, led by Emma Wolf. I know many people attended the event that she led last night, and I know there's also a career panel that is coming up. And that's really designed to engage the next generation of folks who will be working on digital mental health. And then the implementation work group, again, the description is in chat. And there, what we're really thinking about is how can we work towards sustainable models of implementation. So we hope you will all get involved, and just watch for the link at the end of the day today. And with that, welcome everybody. We hope you enjoy day 2 of the conference. And it is my pleasure at this time to invite our panelists out to join us. And I'll start doing introductions for them as they come out. Welcome, Amy. So today's panel is on making digital mental health work for marginalized communities. And we have an absolutely fantastic lineup here. So let me do introductions and then we'll go ahead and get started. So thrilled to have Dr. Amy Green here, who is a clinical psychologist with 2 decades of experience leading research on youth mental health and well-being. And as Hope Lab's head of research, Dr. Green focuses on leveraging technology to promote thriving and health equity for young people, particularly those who are LGBTQ+ and BIPOC. And prior to joining Hope Lab, Dr. Green held an academic appointment at UC San Diego in the Department of Psychiatry, and most recently served as the Vice President of Research at the Trevor Project. Welcome, Amy. Thrilled to have you here.
Thanks so much for having me.
We have Dr. Rob Bossart, who is a professor in the Department of Psychiatry and Behavioral Neuroscience and principal investigator for the Appalachian Mind Health Initiative, a clinical trial of electronic cognitive behavioral therapy for patients who are being treated for depression in rural areas. Dr. Bossart has been widely recognized for his work in the areas of psychiatric epidemiology and suicide prevention. Welcome. Great to have you here.
Thank you. Pleasure to be here.
And Dr. Johanna Folk is an assistant professor, attending psychologist, and the associate director of the Juvenile Justice Behavioral Health Lab at the University of California, San Francisco, at Zuckerberg San Francisco General Hospital and Trauma Center. And Dr. Folk's research focuses on understanding and addressing the behavioral health needs of youth and families impacted by the legal system. She uses community-engaged and longitudinal research methods to examine the effects of adverse childhood experiences, structural racism, and legal system contact on adolescent trajectories. Welcome, great to have you here.
Thanks for having me.
And last but definitely not least, thrilled to have Kay Nikiforova here, who is currently the head of clinical and research at Violet, and developed Violet's proprietary cultural competence benchmarking algorithm and education framework. Many of you got to hear a little bit more about Kay's work yesterday. They advise startups and digital health organizations and regularly lecture and speak publicly on health tech and access to care issues. They are currently pursuing their PhD in clinical psychology with a clinical and research focus on LGBTQ+ identities, cultural competence, trauma exposure, and mental health literacy. Please join me in welcoming Kay. Thank you so much all for joining. What I thought might be a good place to start, there's a lot for us to talk about here. I'd love to start by having you each maybe note your connection to today's panel topic and highlight what you see as 1 or 2 of sort of the key steps that you would hope would happen if we want to advance digital mental health services in marginalized communities, and particularly highlighting those that are sort of often missed by those that are designing or testing these apps and platforms. So Kay, why don't I start with you?
Yeah, absolutely. I'm really excited to be here. And my answer is going to be a little bit similar to yesterday. So apologies for anybody who heard me say this. I think the first thing is just data, having appropriate data on both the patient side and knowing who patients are, knowing who individuals who are accessing digital mental health offerings are, to be able to see if there's parity in terms of the use, in terms of the efficacy, and then on the other side of those delivering care. And I'll use providers, for example, also knowing who the providers are that are delivering care, if it's part of a virtual care model, and then also the individuals who are creating the technology itself, our team's representative. So I'll end there.
Yeah, terrific points. Who would like to build on that?
I can. So I do a lot of work with youth and families who are impacted by both the legal system as well as child welfare system. And I think when we're designing like apps or digital health interventions for marginalized communities, it's really important to be involving the intended users right from the get-go, from the point of when you're deciding what you actually might be designing in the first place, and then including them all along the way. So really doing true community participatory design work. I think in addition to that, I would encourage folks to think about culturally kind of tailoring interventions from the get-go rather than just always kind of adapting. I think cultural adaptation is really valuable when we have existing evidence-based interventions that we're trying to adapt to different populations. But I think often the data that we have on these existing evidence-based interventions has been predominantly tested with white folks, upper middle class, right? And so we don't even know enough, I think, about how they work for different communities. So designing from the ground up.
Can I ask you, just for people who may be less familiar, for whom this topic is a little newer, to explain the difference between cultural tailoring and adaptation for folks?
Yeah, absolutely. So I think the distinction I would make is cultural adaptation would be taking an existing kind of evidence-based practice that was designed for one community and adapting it to the needs or the fit of a different one. So it could be taking kind of CBT and adapting it specifically for Latinx population, for example. Tailoring would be, I think, from the ground up, thinking about the needs of the community you're trying to serve and really building with that in mind from the get-go.
Great, thank you.
Yeah, I'll just add on, also working primarily with young people, as Dr. Folk has the importance of involving them early in the process in co-creation and co-design, particularly when you're working with, at Hope Lab, we mostly work with BIPOC and LGBTQ young people. I think that oftentimes we know that there are certainly less interventions available for young people because it can be tricky, right? Like the developmental time period. And for sometimes folks will say, like, I have an idea for an app for the youth mental health crisis that we're experiencing right now. And they'll have it range from, like, age 8 to 25. And there are a lot of developmental considerations within there. And an 18-year-old is going to pick up on something that was designed with a 10-year-old in mind. And so the feedback that you're able to receive, both in terms of the content, but I think the other piece that gets missed sometimes is content is incredibly important. And without content that resonates and is effective, but also thinking through the engagement piece and the other parts of the process when you're designing, how will you get people to not just find it and access it, but how will you get a product that is effective and that people are willing to use over time? And how do you make sure that if you're designing it for populations, so for example, in our work with LGBTQ and BIPOC young people, that you're responsive to needs? And so that includes things like, even when something's released, having options for ongoing feedback, being willing to change and adapt as needs in the community change over time. And I think that that's something that's really nice about digital interventions, is the ability to build platforms that can adapt and can change, and to have those relationships. And so the other part that I would say, there's the co-creation, and then just developing relationships with the communities that you serve. And so those can be community partnerships. They can be, for folks who are developing telehealth therapies, partnering with something like Violet, where you have expertise and cultural competence, where you can have that growing need over time, but building in the ability to adapt and change and learn in your tech-based services as well.
No, that's great. And just to follow, go ahead, Rob, and then I'll come back.
Yeah, sorry. I was just going to add, I think I represent a slightly different population in this. So most of my work has been done with residents of rural communities who are older. And so some of these comments about cultural tailoring and understanding the needs of potential barriers, and also doing your background work up front to be able to check some of your expectations that turn out not to be true. As I talk to people about implementing these in rural areas, I hear a lot of concern about technology or technological literacy or reluctance to use that. Turns out not to be true at all. The bigger concern is understanding how marginalized populations, in this case, rural populations who've been economically and socially marginalized over time in Appalachia, are willing or able to buy into the institutions that these technologies are representing. And there's a trust issue, as well as an integration with, or need for understanding integration with, traditional care providers in those communities, and how this can be addressed, because the relationship between some of the patients and primary care providers in these smaller rural communities is much different than, I would say, a consumer model that would be in other areas.
You're all making such great points. And I think there's, a lot of convergence across the issues that you're raising here. I want to ask a follow-up question, but first I neglected to mention, please feel free to use the Q&A option there to add your questions for the panel, so that we have a chance to, we won't get to all of them, but hopefully we'll have a chance to get to some of them. I want to follow up because I think one of the things that's happening in the field right now is people have sort of gotten some buzzwords of like user-centered design, co-design, building relationships, community partnerships. But they don't necessarily, and I'll include myself in this, I feel like it's a journey of learning, and each round we do it better, I hope, but have a long ways to go. Can you talk about practically, like, what does it look like to do that as concretely as possible in your experiences? What has worked well and maybe what hasn't worked so well, that so that people can understand in kind of concrete terms, what does it really mean if you're saying you're doing user-centered design or doing co-creation of the work? So Amy, why don't I start with you in this?
Sure. And I'll say that in the flash talks today, a member of our team, Emma Roman Senegal, will be doing a session that will go into some of the details about some of the work that we do at Hope Lab. And so that's a place to get a little bit more detail. But I can give an example that Emma will talk about, which is a product called IME, which is an online web app for LGBTQ young people that Hope Lab developed in partnerships. We talk about partners, and this is part of dissemination partnership with Centerlink, which runs LGBTQ centers across the country, and the It Gets Better project. And so the team initially prototyped a tool they wanted to support LGBT young people and thought, a chatbot, this will be great. They had already had experience with young cancer patients. With a chatbot, they'll be able to get experience. And so that's a prototype, right? They developed this rough sketch of it, and then they started taking it out to LGBTQ centers across the country. This was right before COVID, and then translated into online focus groups, and young people ripped it apart. They didn't want it. They weren't interested. This was not what they wanted. And so in going around and talking to users, and so there was a focus primarily on BIPOC and trans LGBTQ young people. They found out that what they wanted was something that was easy to access. They didn't want an app on their phone. They didn't want something that other people could see. So that's why it's a web app. They wanted something that was not just all about the negatives, that helps support them. And so there's modules on coping skills, on exploring your identity, on queerness. There's parts of joy. They wanted to see styles and features that were more, there's like some like TikTok style clips and things in there. They wanted small bits and pieces. And so it's really going from the idea of a team of researchers and designers who said, yes, we have success here. Let's do something similar and adapt it to be an LGBTQ. And when talking with the community, co-creating, they worked together. They continued to listen to young people to develop prototypes of what if it looked like this, refine to get to the place where when it was released, it was a product that like young people's stamp is all over this. It looks very different from what the team started out with. And that's how I think of co-creation and co-design, which is you come to people, you say, we have a problem we're trying to solve. Here's some solutions we're thinking about. And then you take that feedback and integrate it. And it's still, we still ran a randomized controlled trial with it. It still had within the guides evidence-based strategies. And so it's not the idea of just like a free-for-all, but really creating something together that met everyone's need.
No, I really appreciate the point you're raising, that I think there's some misunderstandings in the field of thinking that if you are doing community partnerships, doing co-creation, that you're moving away from rigor, when in fact it's not at all the case, that you're adding rigor to the process and doing it much more systematically and much more effectively and efficiently. Kay or Johanna, would you like to add anything, or Rob?
Sure, I'm happy to go. So I also will give a shout out. One of my clinical research coordinators is giving a flash talk on one of our projects, Elizabeth McBride on Project Race. You'll hear about that. I'm going to talk about our foster space project, which was with transition age youth who are aging out of foster care. And we really wanted to tackle the problem of kind of the gap for foster youth in accessing mental health and substance use services. And so we started by doing focus groups with foster youth in the Bay Area. We really wanted to keep it kind of more local. So we did some focus groups trying to understand what they saw as kind of barriers to accessing care, with the idea that we wanted to create a digital solution to that. From there, we ended up hiring some of them as actually kind of staff at UCSF to work on this project with us. And so we created kind of an advisory board, or they call themselves the Fab Four, and they really helped through the entire design process with us. And we met with them weekly for almost a year, where we really co-designed, meaning thinking about kind of what does an app look like? What are the features that it has? What does it mean to access care? And what they came up with was a little bit of like not quite care on demand, because it is clinicians who operate within business hours, but they can access service navigators. They can reach out to actual live clinicians and access mental health services. They can access peer chat within the app. They can look through resources on their own. So they really help to think think through exactly what they wanted to see in the app. And then also even down to what resources got included and their own experiences with resources in the community, and ones that they have found to be helpful or accessible for foster youth, ones that they haven't. And so have really kind of built out a lot of that content really from the ground up with us. And that's really that co-creation process, and are continuing to work with us to build additional features and build out peer support. And the idea really is that they get access to evidence-based care. And we have models of how we do service navigation when they get linked with an actual live navigator, but they can do it independently as well. So it echo to, we're not trying to move away from evidence-based practice with this kind of solution. It's really linking them to it.
No, that's a beautiful example. Rob, did you want to share your experiences in that space?
Yeah, I would say, ours is just a little bit different. Our recent experience, we didn't develop the app. We're developing a system of care. So a lot of the feedback that we've received is more about concerns and development of strategies to accept the digital tools as a trusted agent. So overcoming reluctance for using something that at this point is not trusted. So it's been a lot of what we've already heard, focus groups and involvement early on about how can we culturally tailor our messaging, at least, or our approach in a way that increases the acceptability, but also making sure we have diverse representation on our leadership team. So persons with lived experience, those who are advocates for persons with lived experience, as well as treatment providers. So we have a full spectrum of voices to help us understand where we might encounter some barriers or reluctance.
Okay.
Yeah, I can definitely jump in. I'll echo a little bit of the leadership piece in terms of the development of technology, considering who's in the room. An example is who's always missing. I'm thinking about in this panel, who's missing from this panel, who should be on this panel, especially communities that aren't represented. So that's one thing that I point out. I'll use a very specific example from Violet. In the earlier days, I created our education framework in terms of how we like to educate, in terms of strength-based, in terms of really community-oriented, and also acknowledging that I'm not the person to make all this education. And so one of the things that we've developed, we have a very, very robust network of educators who have clinical expertise, so between primary health and also mental health, and also have lived experience with a particular community. We don't have individuals write about communities. We have individuals write about their own communities. And so that's created a very different experience of providing culturally competent education to clinicians, because it's not theoretical, it's not hypothetical, it's individuals sharing about their own lives and the way that their communities are affected by health disparities and also the strengths. And on top of that, we also have a clinical QA advisory board who are, again, individuals from the community reviewing that education. So for example, all of the trans-related TGNC trans-related education that comes through Violet, I've reviewed. In part because of my own experience with the community, but also my own clinical expertise. So I think it's building layers of understanding that not everybody's experience is a monolith for our community, but acknowledging that it's going to be much more effective and also much more impactful if I know that who's writing this actually knows what it's like to be a part of that. So embedding that not just as part of education, but also embedding that as part of care models, involving people who are going to be actively affected. We started Violet in part because our communities couldn't find good care, so that's a piece.
No, that's great. One of the things that's clear is that it's going to be, multifaceted solutions with many different stakeholder groups sort of playing roles and trying to increase access. And I wonder if you could talk a little bit about the distinctions among those roles. So what is it that you would envision, sort of what researchers should be doing versus industry folks, providers, funders, community leaders, there's so many different sort of stakeholders who are involved. And what would you hope that they would sort of be doing in their different roles, and how can those be coordinated if we want to sort of be effective increasing access to high quality services? Why don't we start with Rob this time, since I haven't started with you yet?
Yeah, and I think I represent, in my own specific lane that I stay in, I'm more in the research lane. So I can tell you from my perspective, I would hope for better integration. I think we've got good communication and good interaction with our communities and our target communities and trying to understand what their needs are. My gap is with providers on that side, to be able to have better interaction with other care providers. Traditional providers would be caring for these patients, and finding a way to have better integration of some of these digital solutions, at least buy-in for them, so that they can feel supported as they're both utilizing the tools that we can bring to them, and they're seeking other forms of care from their primary care providers. For me, I think that's the big gap that's missing.
Anything else that people want to add to that?
I'll build on the research side in terms of thinking about the translational pipeline. I think that we've pretty good. Everything could be better. The funding for research mechanisms to develop and test applications. We don't have great funding to develop and test relationships. They're out there, like Precori and some others, to have that co-creation process. And so just thinking from the funding structures in terms of what would need to change, right? Like the developing relationships with other clinics and practices, that takes time. And
Sure.
when you're a researcher and you're in academia and you have a lot of other things going on, it's really hard to do that when it's not something that's necessarily rewarded by the institution or by funding agencies. And so I think a change in how we approach that part of research. And then the second part is, once something is developed in a research setting and it's proven to be efficacious, it's really hard to do the next step and to get funding for the pieces to actually turn that into something that scales and it goes to play. And I know this because I came from settings in academia where things would sort of end there. And then I came to work at places like the Trevor Project, where there's massive marketing and communications teams and places that get things out there. And it always strikes me of the gap of how much really good, incredible research and interventions have already been developed, how much good science is out there that we just can't get into these scalable mechanisms. And so I look at changes in funding strategy as a big piece of what would get us there, because I think researchers are doing incredible work. I think there are lots of people doing work with marginalized communities, creating interventions that are like showing good results on a small scale, but getting them to the places where they're digestible by the masses. To me, that's like a big place for hope and investment.
I can jump in as well. I think, well, part of the reason why I was so excited about this year's event was in part because of the topic, the bridging of academia and industry. And simultaneously, I think that the dichotomy of academia versus industry is very, very artificial and actually actively upheld by both of them. Academia is an industry. It's just not the one that we conceptualize. And so one of the things that I spend a lot of time doing is actually talking to individuals on both sides who really want to do that crossover. And I find that the gap is actually not that wide. I think there is this conceptualization. If you talk to clinicians and researchers, tech with a capital T feels very intimidating, and also vice versa. Individuals in the health tech space just not knowing how to read a research article. It's those types of things. And so this is an area that I think about and try to spend a lot of time bridging. It's actually interesting because I go to academic conferences. I was just at one this weekend and talk about health tech. And I go to health tech conferences and talk about research. So it's it's always kind of a bit of a mismatch. So what I'll say on the academic side, I think that sometimes there's a bit of an idealism involved in the way that just digital health companies are run, venture-backed companies were run. I had mentioned this last time. We are in our healthcare system is capitalistic. Venture capitalism is capitalistic. And while a lot of us probably are not particularly thrilled about that, that's how the money gets there and that's how the money is going. And so the difficulty of feeling like it's appropriate to build a business case for something that makes sense ethically and for something that is efficacious feels wrong. And simultaneously, that's the only way that these things happen, because a lot of the work that Violet does is just logical, good, effective, and simultaneously there still have to be the slides with the ROI, right? That's a lot of the work that I do. So I think it's important to understand that. I think come to terms with it, and also still within that, I do believe if you do good, you are going to make money. That's like my own controversial viewpoint. And so I don't think venture capitalism is excluded from having ethical and efficacious care models. And on the industry side, I think that clinicians and researchers just need to be in the room when these things are being created. One thing that I'm seeing now is, within the first 3-5 hires within new health tech startups coming up, there's going to be a clinical leader. And that was not always the case. And oftentimes companies backtrack because they realize, oh, right, we built all the tech. Now we need to build the clinical side. And so I think clinicians being there at the start, researchers being there at the start, I think now we're seeing that health tech companies or digital mental health companies need to have clinical leadership and also need to start research immediately upon creating their products, because that's also they're needing to show evidence for fundraising. They're needing to show evidence for their customers. And I think it's actually a really good sign for us moving forward as a field.
No, 100%. And we need to see academia sort of also recognizing steps along the way and incentivizing that, right? So that it's not just a journal article or a grant that's rewarded, but like building those partnerships is recognized. When people do dissemination, when they're working with industry partners, like that's actually a really important role to take on, but not currently well recognized in most, institutions. Sorry, Johanna, it looked like I accidentally cut you off. Go ahead.
No, that's okay. I think these are all such good points. And I think the incentive structure in academia is really problematic. For the true partnership building and doing the work. I think the other piece to think about is, as researchers, we could probably do a better job of thinking about scalability from the get-go as we're designing these digital health tools. And I think we often don't think about that step. I also think it's useful, even if you're staying in academia and not going into like a venture capital type startup, to check out some of their events and get some training to understand how folks more in the corporate world are thinking about these types of problems. I participated in like a startup launch boot camp kind of program just to learn the different skills. And I think that was really valuable in thinking about how we were building our tech and what the next steps were. And at least certain institutions do have kind of pathways to support faculty to kind of bring their products to market or move things more into that direction, if that's how you want to go with scalability.
No, it's a great point. And I think it's important that we're getting that down to graduate student level as well. So there are some programs, like NSF has I-Core and things like that, that are these kinds of training programs. But I think it's really important that we start to think about how students can be learning these skills and getting these opportunities also in their training.
Bethany,
Great point. Please go ahead, Rob.
Real quick.
Of course.
I just want to mention some perspective. I think it's really interesting. I'm so glad we talked about capitalism. So thank you, Kay, and business models. Because one of the things that we've learned in our work in Appalachia is that a lot of these digital tools are direct threats to the business model for the existing clinicians. And we don't often think about that. We had some really unexpected and unanticipated pushback from the clinical primary care providers in a lot of our rural communities because it threatened their business model. So treatment of mental health is a large part of the business for a lot of these smaller clinical offices in rural areas. These tools offer a cheaper, more accessible, more scalable solution. So I think as part of the work, at least that we're doing in some of the rural communities, is thinking about what are the traditional pathways to care for a lot of residents in those areas, where the points of opposition they're likely to meet. In some cases, it's exactly the people that they're turning to for help. I just want to mention that the problem is compounded by the fact that digital tools are not a trusted agent. I know I've used that term before. There's a lot of pushback. When we first showed up with the project that we have now, and we said, hey, we're a bunch of smart people from a bunch of great institutions with these really cool technological tools. We're here to help. There were 3 strikes against us already, right? They don't trust the institutions. They don't trust the digital tools, and the people they go to provide them with guidance we were representing a threat to their business model. So it was a lot to overcome. And I just really appreciate the comments, not just about how you think about building something like this, but how do you think about working with the existing infrastructure in some places?
No, these are terrific points. I want to make sure we've got a number of questions in the queue. So let's turn to some of those and see which ones we can hit. An interesting comment came in, Kay, you mentioned research articles and sort of their readability in some cases. And a comment came in also about sort of that in some cases, whether it be because of page limits or other constraints, that what gets written up in a research article is often limited and doesn't give people some of the tools they need for readers to be able to like really learn fully from it, so that they could then take that work, whether that be replicating, extending, or whatever it happens to be. Can you talk about what you wish journal articles looked like? What should be different in them if we were to be more inclusive, be more effective in disseminating information so it was useful for different folks to be able to actually learn from it? No thoughts on journal articles. Okay, fair enough.
I'll include a thought on journal articles and I mean, community-based research shout out in general, obviously. I think it's kind of like the obvious point, but probably going to say something a bit controversial in this, but especially as we talk about bridging academia and industry, especially for working with historically excluded communities. I think I'm going to go back to this piece of ROI, and it's so interesting to think about it, return on investment. And I think, you know, a lot of the literature reviews that I do personally is actually trying to find some of the financial benefits of engaging with some of these. I don't think in an ideal world, I wouldn't have to do that. That's my big caveat. And at the same time, that's a lot of what I get asked for, because it's not, you know, how efficacious is this? What are the benefits? It's okay, well, what is the dollar amount that's going to come back on this in addition to all of those things? And while I don't think it's appropriate to tie dollar amounts to everything, I think that oftentimes research articles don't include the sort of more business side, or I'll do implementation side of things, of even in future directions or things to consider. I wish that there was a little bit more thought towards that, because good research is wonderful, and also good research that can't actually be implemented within this space makes it very difficult. And I sometimes struggle with research specifically focused on digital mental health, in part because the individuals aren't really addressing how this is going to be practically implemented, which also is going to not be particularly helpful to those implementing it.
That actually leads in well to one of the other questions that came in. So you talked about implementation. This question is about sort of sustainability. So a comment from saying, thanks for the interesting panel. How do you think about sustainability in your research within these communities? For example, sustained funding, technology, infrastructure, et cetera, to continue to deliver the technology or intervention after the research concludes. Yeah, it feels like $1 million question.
I think a couple of pieces that come to mind for me are like buy-in of the community that you actually want to use the app or the digital health solution that you've created, but then trying to create tools that work within existing systems, I think helps for sustainability. Like if you're working with providers, can you build a tool that works within an existing clinic that they can adopt into their workflow, and therefore it will be sustainable when your funding ends after you've evaluated it through a trial. I think a lot of times we just build standalone tools that we like hope will go out into the world and just be picked up with no kind of strategy for funding or market after that. So I think working in existing systems can be really helpful.
And where have you seen that done effectively?
You know, I do a lot of work within healthcare settings. I think we often actually fail at this because we don't really understand the nuance of like clinical workflow or what providers need. I think when you can start from the ground up of trying to figure out what a problem the providers want to solve is, and then working with them to build the tool and then testing it out in their setting, that can be really helpful. So we've done that locally within some of our public mental health clinics with building, again, like a service navigation type tool. And I think that's been a little bit, it's been challenging because there's turnover in the mental health workforce, and you can have buy-in from some folks who then leave midway, right? So I think it's not an easy process to do it regardless, but I think that's one approach. And I do wish on the journal article that people would talk more about some of these kind of challenges to building and sustaining the partnerships along the way. I think we often just like talk in our procedures like, oh, I just recruited all these folks and they tested this app and that was great. But we don't talk about, I think, some of the challenges or all the work that went into building that relationship that I think is so crucial to actually being able to do this work.
Yeah, I mean, Amy's comment of meeting weekly for a year to build those to do the co-creation work and build the relationships, like that's substantial. And people need to understand kind of what's involved. Kay, were you about to jump in?
Yeah, I wanted to go back to my first data point. And this is a bit of the way that we've evolved, at least in Violet, in terms of the work that we've done. Because one of the things that you, in terms of historically excluded, historically marginalized communities, there are so many verticalized digital health platforms, virtual care models, and it's very specific toward a community, and oftentimes toward the type of care that they're going to be receiving. And of course, there's many of those coming out. And the way that the cultural competence benchmarking framework got started was actually through a care navigation process for a queer competent mental health care marketplace. It was a process to really assess whether clinicians were competent and then being able to connect them with queer patients. And that was wonderful. And it was also financially not viable in terms of a business, right? Because of all of this verticalization, actually at that time, it was a couple of years ago, that was just kind of the thing that was coming out. If there's a gap in care, let's do care for that particular community. But of course, when that particular community needs mental health care, or that particular community is also part of another community, that's where it gets very tricky, especially between race, ethnicity, and sexual sexual orientation and gender, there's, the intersectionality oftentimes in care models may not be there. So what we ended up doing was thinking, okay, well, we could continue to try to do this marketplace, or we could actually just use this framework as a data framework. And I think a lot of times I don't really see those types of pivots happening. And we pivoted not because it wasn't successful, it was because it was actually really useful for other communities as well. So then we built out this framework, and then we decided all clinicians, these 3 communities that we serve, and let's just kind of get in the payer, get in the health systems, get on the individual clinician level. And I think there's like those interesting moments where even if it's a good idea, if it's not financially viable or translatable into industry, there are options, and the conceptualizations can still be used in an effective way.
Great points being raised. One of the other comments that came in is an interesting one, and I'm just curious to hear the panel's reaction to it. So, Society for Digital Mental Health talks a lot about bridging, and many of you, industry and academia, and getting stakeholders talking together. And many of you have talked about, those same goals in your responses. We had an interesting comment come in that says, I agree that it's important to build bridges between academia and industry, but I also think that it's essential to keep them separate. It's a healthy separation of powers that has worked for centuries, and that creates the checks and balances that prevent academia from blindlessly serving global capital interests. So a very interesting comment. I'm super curious to hear your reactions to it, parts that resonate, parts that don't resonate with that. Add a little controversy.
I think to me, the key is the bridge part, right? Because we're not saying throw everybody, like cross-pollinate everyone in all of the places, right? We're finding ways to take the richness of academia and have industry benefit for it, so that, because if I think of the end goal, it should be, right, that we want to see a better society. For this panel in particular, we want to see populations that have been historically marginalized and oppressed be in places where we're better supporting their wellness and their well-being. And so that's probably going to not happen in any one of these industries when they're completely siloed, right? Industry without rigorous research isn't going to be at a place where we're probably developing things that are from the ground up efficacious. Academia in a silo isn't going to hasn't had for years the skills to take things to the massive scale. And so I don't know how we do it without putting a bridge in place. We speak different languages. We have different goals in different ways. And I think that that's okay if we have a common goal. And there are a lot of, we're not talking about every single part of industry. We're talking about academia coming together to help in the parts of well-being. And there are a lot of really mission aligned industry out there. If you talk to we talk to a lot of founders. If you talk to a lot of founders are in this when they're in mental health for marginalized populations because they have lived experience in it, because they have struggled with it. And if you think of it from that way, these are people who are trying to solve a problem. We're all problem solvers. And the best way to solve problems is to use some of the best aspects of both. And so I don't know. I still argue that we need a bridge. I have not been swayed that we don't need a bridge. I don't know that we need to all be in the same spaces. I agree that there are places in both that are separate, but I don't know how we make progress without putting some nice, sturdy, easy to access bridges in place.
I would also just like to add that I think that's great is I'm in a school of medicine. I'm just going to say we're as capitalistic as anybody else, right? We are as profit driven. If I don't bring in money, people don't like me as much. So, I strongly agree with what Dr. Green just said. Those bridges, I think, are necessary. I think there are parts that are better if they're truly academic, some very hypothesis-driven, pure research pieces. But I think industry can bring things to scale, bring innovation, specialized skills, and the tools to the table that academia just can't take and doesn't have the time or resources or degree of specialization to build. So for me, it's critically important, not just for translation, but for filling in those gaps that academia just doesn't have by its very nature. I think they're critical partners. I see it sort of as an artificial divide. We just happen to live in different sectors, but a lot of us are mission driven in a very similar way.
Yeah, I think, and I would just add to that, that like, as someone mentioned, there are very values driven companies out there. And I think it's just important to know who you're going to be working with when you get into this kind of a relationship too. Make sure that you do actually have values that are aligned, that you, if you're going to be evaluating, let's say an intervention that a company has developed, that you do have license to do that really independently and bring whatever the conclusions are, right? Just kind of thinking ahead about what the agreements and expectations are as you get into that kind of a relationship.
No, excellent points. Let me turn to a question that came in that feel free to either say an answer or type it into chat so people can have a record of it. So I've struggled with understanding how to develop profitable and morally sound businesses where there is real alignment between helping populations and generating an actual ROI. Any resources like books or blogs that you like that you would recommend to help find paths within the US healthcare situation? So if you have sort of favorite resources that you would encourage someone to refer to, book, blog, whatever, do you want to share that, type it into chat, whatever is your best method?
I'll type a couple of things into the chat, but I did want to kind of, first of all, I think it's a wonderful question. It's probably all of us are trying to actively solve that for ourselves. But I think a lot of what I see in unsustainability within digital mental health is is creating a solution before there is a problem, or knowing or trying to retrofit a solution into a problem. And so I think the way that it's worked the best is if there is a true problem and then a true solution, that process is much easier to actually generate an ROI for. So it's actually kind of like sound process. You're able to come up with a reason why this makes sense rather than retrofitting. So I'll kind of give that as a shout out, and then I'll put in some resources in the chat.
Wonderful, thank you. Question came in, excellent panel. I would be curious to hear the panelists' thoughts on the role of mental and behavioral health specialists in advocating for policy, legislative, and other structural changes that foster improved funding mechanisms, health equity frameworks, et cetera. So we've been talking a lot on the sort of industry research partnerships, but of course, that sort of legislative policy side is absolutely essential as well. So if you want to share any suggestions, comments, or experiences in that space.
My easiest suggestion, which is that unless you already have a built-in advocacy network, is to find the advocacy orgs that are doing the work, and ways that you might be able to partner with them. It's actually some of the most rewarding and interesting and frustrating and amazing aspects that I've had in my career are working with that bridge between research and advocacy and policy. Advocates and advocacy orgs love data, they love science, they love numbers to back up what they're doing. And I would say that the best way to be supportive is probably to work with the groups that know the ins and outs. It's super complicated, all the rules in lobbying and the connections and time that these people put into developing the relationships with different policymakers. And so I would say for someone who's wanting to get started, to connect with look up some of the larger, either local or national policy orgs that are doing work in your area, and then contact them and see if they have opportunities to collaborate and connect.
Great suggestions. Johanna.
Yeah, I agree. I would say, yes, we do all have a responsibility to do that. I think I don't necessarily believe in just generating knowledge that sits in like academic journals and doesn't serve the kind of society or the greater good. So I think too, I would say getting involved at the local level can be really powerful depending on where you are and what local politics look like. I think that's where we can affect a lot of change. I think national movement, it takes maybe a little longer to trickle down into the local level and see more dramatic changes. So I think great to get involved with big national orgs where you can even go to an advocacy day, get training and that, learn about how to talk to politicians if that's a space to do it. But there are lots of opportunities locally to make changes too.
Yeah, and if
Yes,
I could, yeah, I'd just like to add that, all observing the need for objectivity in research, I personally think that research is advocacy, and we have a responsibility to use the findings that we have to advocate on behalf of those that we represent through our research. I've found that working with the congressional liaison at the university is a great way to get to politicians and policymakers. Often results in a visit to Capitol Hill and a sit down, usually with staffers, about the importance of the work you're doing and the importance of continued funding. And that gives you a chance both to represent the findings and the groups that you're working with, but also make a pitch for continued or increased funding in those areas.
And I think that's such an interesting and excellent suggestion. I want to make sure that we're being as concrete as possible so that people can take these ideas and really implement them. So Rob, what's your advice? So if someone wants to, is working in an academic institution, wants to reach out to the congressional liaison, do they do it when there's particular legislation that they think is sort of relevant? Do they do it just to form a relationship? How would you advise like someone to practically kind of go about setting that up so when the time comes, they are in a position to kind of, make contributions and advocate?
So the broad answer is yes, right? I think as much contact as you can have is early on to both, even if you don't have research yet or projects yet that you could bring to their awareness, you can still sit down and talk about the importance of the topic, maybe educate the policymakers on either the work that you're doing or the population that you're working with, the importance of that work. And that gives you a chance to be seen as a resource. And I've always been surprised at how frequently people end up calling on me then when they have legislation that's come to their desk and they're seeking some expert opinion or some opinion on that legislation, how important it is. So I think relationship building early on and outreach early on, even if you're not necessarily advocating for a specific project or specific piece of legislation, gives you that opportunity to begin that dialogue. And almost I'm in a university setting, but almost every university has a liaison who's representing the interests of that university at both the local, state, and federal level. So there are multiple opportunities for impact. And, I personally, the more I progress in my career, the more interested I am in local impact. So I'm looking for opportunities within my community to be able to influence change.
I also wanted to call out at this time, and I love everybody's answers. At this time, there's so much movement at the national, at the state, at the local level of translating health equity into something that is tangible, into something that is metrics driven, into something that creates accountability. And it's been so interesting to watch even over the last couple of years, how much that has changed between class guidelines for education for clinicians. Different states have been really kind of leading the charge. We had some conversations with folks in Colorado where they were interested in some sort of accountability system. And so I think there's also this opportunity, if individuals are working with communities or from the communities especially, to really start moving themselves into the advocacy of this sort of wave of health equity initiatives and also legislation, compliance, regulation, especially. That's one thing that I'm really excited about at the payer level, at the health system level. And I think on our end, what we can do is instead of having to kind of come up with what it is, like we could just offer support and offer evidence for what individuals are already doing. I'm really excited because each year more and more of these things come out and there's more and more accountability, and that accountability is going to require quite a lot of research for health systems to prove that they're doing what they're supposed to be doing.
Yeah, I agree. I mean, it's a really exciting time in the field right now. It feels like there's so many opportunities, and yeah, hopefully more backing to actually make these things come to fruition than has been the case in the past. Gosh, we only have 3 minutes left, which is not enough time because we have a whole list of questions here. Let me see if we can fit 2 more in quickly. One, an interesting one, are there conflicts between clinicians? When there are conflicts between clinicians and tech teams when designing product features, how are they resolved? Who gets the final say? Sort of a broad question about if clinicians and researchers suggest a feature that doesn't help or goes against the bottom line of the company. What happens in those situations?
I can jump in for that one because, I've sat in those rooms. I think the first thing that I'll say is that I think if clinicians choose to do work within the industry, there needs to be an upskilling of oneself to understand how to speak that language. I think things can be effective and also really help with the bottom line. But I think part of our work, clinicians, researchers, is to start to understand how to speak some of that language. And on the other side, tech teams are starting to understand that they can't build without us as well. But what I'll say is sometimes, at the end of the day, it's also our job to say, I've stood up in rooms and said, like, this is actually unethical. We cannot do this. And if I need to build a case for why we cannot do this, I'm willing to do that. But sometimes you just need to take that conversation.
Great point. So final question, just very briefly, because we only have a minute or 2 left. We were asked, what successes have we seen in the technology support tools for providers in offering effective care to marginalized communities? So we've talked a lot about barriers and challenges and things like that. Let's end on a success note. So if you want to each highlight just one short example of a success story that you would want to feature, why don't we finish with that? Amy, do you want to start us off?
Sure. So I'm going to do a quick one, which is that Kay may know. So InStride is a partner that Hope Lab has worked with. We've worked with their providers, with young people to do that, help them develop the service. And then They came out of an academic institution, they're scaling their services, so it's academic process, and then they've partnered with Violet to ensure that their team is able to culturally competently serve young people and families. And so just a great example of academia making it into industry in a mission-aligned way and ensuring that the services are provided in a culturally competent way.
Wonderful, Rob.
Yeah, sorry, I take myself off mute. Yeah, I would say for our project, it's been the buy-in we've seen from the clinical community. It's been slow, but the state level clinical organizations have come on board, some both supporting our work and trying to help us find ways to integrate it. It feels very much like something that started as a threat and on the outside has begun to make its way into more of a continuum of care. And we're very pleased about that.
Fantastic. Johanna.
Yeah, I would say I'm really excited about a newer kind of project we're doing, which is we built kind of a web app with caregivers whose teens have been in juvenile hall, and we're getting ready to roll that out into some systems in California. And there's a lot of excitement, I would say, from folks working in juvenile hall around it, which is pretty rare to see with like kind of digital tools in some of these systems and open to it. And the caregivers really have invested a lot of energy. So I think it's just excited to see where that goes.
Fantastic. And Kay.
My end, one of the things that we've started to do is start to integrate our benchmarking data or outputs into care routers or care routers for our partner organizations. And we've started doing research on patient outcomes on their end. And it's been very exciting to see early indications that if you pair an individual with a culturally competent clinician, that the downstream outcomes are just going to be positively affected. So really excited about that, really excited to do more research around it.
Fantastic examples. And yeah, excited to end on this sort of positive note. So just, I know everyone wants to join me in thanking you for just a fantastic discussion today. Thank you for sharing your wisdom and your insight and expertise. I know many of you mentioned that you are appearing in either an AMA or you have students who are other folks from your organizations who will be presenting flash talks or participating in some of our other sessions today. So please all save your questions if we didn't get to them and bring them to those other sessions. And again, a huge thank you to our fabulous panel. We're going to have a short break right now, and then we will return for the flash talks as our next session. So thank you, everybody.